Thank you, Ashwin, for coordinating this session and for helping us to do this session. I would be talking to you about the intraoperative OCT guided anterior segment surgeries. And we begin with the cataract surgery first. So, even in cataract surgery, it has a very important role to play because when you're making incisions, for instance, you're making a side port or you're making a main wound, then you can actually see the level at which it is being made. For instance, here it is going to be a biplanar incision, and that can be seen. When you're doing the capsulorhexis, then you can actually see that there is a flap which is being created here with the help of the cystotome. And this is especially useful when you're doing it in hazy corneas, because even if you lose the flap underneath, you can see it from underneath the corneal haze. Then even the separation of the nucleus from the cortex, and when you're doing hydrodissection or hydrodelineation, you can actually see the disassembly of the nucleus in the intraop OCT. And this becomes useful when you're doing cases of posterior polar cataract. And again, whenever there is any, you can see that when you put viscoelastic after cleaning up the cortex, you can see that the PC is intact and it bows down. Subsequently, the intraocular lens implantation is done, and then when the viscoelastic is still there, the gap is quite a bit, and after the viscoelastic is removed, the gap between the IOL and the PC decreases. And again, when you are hydrating the wounds, you can actually see the hydration of the wounds, as well as you can see if there are small Descemet membrane detachments which may be there at the wound site. And then you know that you need to address them before you finally take a call. So you can see a small wound site Descemet DMD which is there, and so you put air bubble before you finally leave. Now, this is a case of posterior subcapsular cataract, and you have an intraop OCT microscope. You can see that there is a gap between the PC and the overlying cortex. And when you have a white cataract such as this, you can see that there are fluid clefts present. So when you give a nick on the anterior capsule, there will be no fluid which will come out. But if it is a white cataract, which is a little different, where the fluid is present, then you can see as soon as you give a nick, the fluid will come out. So here there are no fluid clefts present. And as soon as you give a nick, the fluid comes out. So when there are no fluid clefts present, you know that this can be expected. Now, this is a case of capsular distension syndrome, and notice the gap between the capsule and the lens. And then after when you remove that contracture rim, again notice that it's bang on the posterior capsule and there is no gap between the IOL and the PC. So it helps to fine tune your surgery. Then if you do have a Descemet's membrane detachment such as here and you put air bubble, then if you didn't have this ASOCT, you would think that you are actually done, but actually you're not done because there's little gap which is present here. And so when you put the air bubble there, maintain some constant pressure for some time. And then you can see that the Descemet's membrane is stuck to the back of the cornea. And then you know that this is your final endpoint. Then again, this was a case referred for corneal transplantation, but you can see that there's a Descemet's membrane detachment there. And if you address that, then without having to do a endothelial keratoplasty, you can still get a clear cornea. It is very useful in cases of big bubble deep anterior lamellar keratoplasty because you can actually see when you do keratectomy and you inject air bubble, you can actually see that the Descemet's membrane falls back, as can be seen here. And as you give a nick on the overlying stromal layers, the Descemet's membrane marches forward towards the stroma as the air egresses out. Then as you again put the viscoelastic like a kangaroo's pouch, this falls back. And then the overlying stromal layers can be excised so that the bare Descemet stares at you over which the graft is put. Now, when you're doing a type 2 bubble, then also you can make out type 2 bubble will start from the periphery, will move towards the center. You just stop short here because you don't want it to go right up till there. Because if you do AC paracentesis, you can perforate the Descemet's membrane. Then following this, the paracentesis is done as is shown here. And there are not one bubble, but there are two bubbles which are present. Very nicely, Dr. Dua has described Dua's layer, and much of work has been done on this even by Dr. Amar Agarwal's group. So you can see that this type 2 bubble is pushed back, and then again the surgery can be done as was shown in the previous case. This is just to show visual acuity of 6.9, 6.12 in a case which was of Hurler's. and the patient is doing well without having to do an intraocular procedure, the patient still sees well. Then even in healed hydrops, it is very useful because you can see that where is the healed hydrops, it will tell you the site, do trephination, and just as you come to the area of the healed hydrops, move a little anteriorly, leave little bit of stroma, and because it is paracentral, you can see that the haze will shift a little paracentral. Here also this can be seen, but it doesn't make a difference as far as the results are concerned. The visual acuity is still good, and you have 52 microns of the tissue at that area of haze. Then again, in SLED, chemical injuries, it is very useful because you can actually make out where the pannus is and where the cornea is. So the dissection becomes a lot easier because in these cases, often the corneas may be thinner and you don't know what the underlying thickness is. And then little pieces of limbal lenticule can be placed onto the amniotic membrane. Now, this is a chemical injury case which healed on just SLED with a visual acuity of 6/6 and without having to do a corneal procedure. Then it is also useful in cases of descemetocele, such as can be seen here post-operatively. Now, when you put a little bit of tissue that is here and you don't suture it, you can actually see that there's an apposition between the two edges, the graft and the host and the recipient. And this gap, when you know it is completely full, then it's completely opposed. That means that is the end point. Then even in hazy cornea such as this, when there's a DMD present and you can't see anything, you can still see it on the IOCT, and air bubble is then instilled. And once you instill that air bubble, the Descemet's membrane is attached, but still some amount of shallow DMD is still present. And when you do the drainage of the fluid from the top, then and put air bubble, then you know that it is attached. And it is very useful in hazy corneas because you can make out where it is going. Then in DSAEK, especially in hazy corneas, which is so much common in our part of the world, you can still make out whether the graft is attached or not. And when there are uh, submicroscopic spaces that are present, which otherwise are not visualized onto the operating microscope, we can see this. In ultra thin DSEK also, when sometimes the graft gets inverted, as is seen here by the configuration of the graft, and by flipping it, one can actually make out and reorient it into the correct direction. And this is the last bit on the DMEK. So the graft can be, of course, stained with the trypan blue dye. The peripherals can be removed. And here you don't actually need an intraop OCT microscope because you can see it because of the visualization and staining of the Descemet's membrane roll with the trypan blue. But it is useful in cases of host because if there are any remnants which are present, then one can make out and can address them on the intraop OCT microscope. Then this is the Descemet's membrane roll which is taken, is placed inside. You have to get that biceps curl up. This is upside down, and again flip it up, get it into the correct direction, and then the Descemet's membrane graft is attached, and you can't make out whether there's any graft which is present at the end of even week 1 or month 1. And this is PDEC, Dr. Amar Agarwal's brainchild. So one can see that there's a PDEC scroll which is present, stained with the trypan blue dye. Then this can be excised with the help of the Vanna scissor. And this is after getting a big bubble. And this is the graft which is there. And this is a case in which it is being done. This paper has already got accepted in Journal of Cataract and Refractive Surgery, the IOCT Guided PDEC. So again, you can remove the Descemet's membrane, diseased Descemet's membrane, put it inside and get it into the correct configuration, and then get it into correct position after putting air bubble in there. I found it very useful for cases of lenticule problems, especially in smile, because you can take the patient immediately to intraop OCT microscope and you can see which side the lenticule is stuck, whether it is stuck onto to the bed or it is stuck onto the cap. And then if there is a problem, especially if too much of needling has been done, then one can rescue this. So these are our publications on IOCT guided surgeries, and very recently we published a review article in Survey of Ophthalmology. And it is a very useful tool, and I'm sure there are going to be more modifications, and there are going to be, it is going to become better in the coming future. So thank you very much for your kind attention.